So hello guys, welcome back to my YouTube channel. So we're going to go with one more PYTs. So I thought actually I will complete hemolytic anemia in two sessions. Maybe I might take more than two because this is definitely an important topic, be it an FMG exam or an NACT or an NEET PG exam, right? So if you're here first time, click on the subscribe button. We'll learn more and more PYTs and we'll discuss the PYTs questions in Instagram and Telegram channel. Please have a look at the link below. Fine. So let's start. As usual, put on a big smile and let's start. See, hemolytic anemia per se, the first thing which I want you to remember is there's a triad for every hemolytic anemia, whichever happens in the body, right? One is there'll be an elevated retic count. That's by default because whenever there's an hemolysis, there'll be a bone marrow response of hyperplasia that will be reflecting as an elevated reticulocyte count. But there are few hemolytic anemia where you have ineffective erythropoiesis. The reticulocyte count will not be that much elevated, right? Second thing, there'll definitely be an increase in your bilirubin levels, the indirect bilirubin or the unconjugated bilirubin levels because of classical hemolysis, right? That's the second one. Third, obviously, it's hemolytic anemia. There'll be reduced lifespan of RBCs, fine. Okay, that's going to be their default, right? So if I have to differentiate whether the hemolysis is happening inside the blood vessel, that's an intravascular hemolysis, versus outside the blood vessel, like in spleen, extravascular hemolysis, there are two classical clues which I want you to look in every question, right? So if I say it's an intravascular hemolytic anemia, which means the blood lyses within the blood circulation, so there will definitely be a feature of hematuria. So whenever you have hematuria or a hemoglobin or a red color urine, it's indirectly saying that the RBCs lies inside the blood circulation, right? If it's going to be extravascular hemolysis, like in spleen or in liver, most likely in spleen, so there'll be a history of on examination finding of splenomegaly, fine. So these two are characteristic clues for me to say whether an intravascular hemolysis or an extravascular hemolysis, right? Perfect. Now we've got the base of hemolytic anemia sorted, right? Now let's go one by one disease and we'll just look at the classical points which will help us to diagnose things, fine. Look at that. The first thing is about HS. So these are the headings which I want you to revise whenever you are revising for the second time or third time, right? First time, read. Consolidated reading, slow, steady, conceptual understanding. Second time, the most important things along revision, fine. The most common mutation in HS is hereditary spherocytosis and carrier mutation. There's no doubt in that. Please do remember, especially if you're preparing for an INICT exam, spectrin can also be mutated, and spectrin mutations will have a very, very severe disease, and spectrin mutations often autosomal recessive inheritance, right? This is especially for someone who's aiming for an INICT because INICT tries to throw a curveball. We should be able to take care of the rare things as well. But otherwise, every other HS spherocytosis is an autosomal dominant with an ankyrin band proteins mutation. It will be dominant, and the most common undoubtedly is ankyrin. It's definitely a dominant mutation, autosomal dominant mutation, right? So because of this mutation, biconcave RBC kind of becomes spherical, right? So when RBC becomes spherical like this, the problem is they'll get caught in the spleen. When they get caught in spleen, who'll eat it? Macrophages. The splenic macrophages, the littoral cells will be very, very hungry and they'll eat it and destroy them, right? So this is a classical extravascular hemolysis. Just now I said, whenever there's an extravascular splenic hemolysis, you will have a classical finding, splenomegaly. You will not miss it, right? It's a dominant disorder where most likely the anemia is very subtle. The patient will not present as anemia. Most likely the patient will present as gallstones because of unconjugated bilirubin or an indirect bilirubin elevation. So if the history says an adult, that's how every dominant disorder will present with splenomegaly, and a gallstone, especially the question is pigmented gallstone. Cholesterol stone, I don't care. You and me also can have because fat, that's all. That's the most common thing, right? You eat more, there'll be a risk. But a pigmented gallbladder calculi can be seen only in two conditions. Remember this: one is hemolytic anemia, other a gallbladder or a biliary tract infection, right? So in this case, hemolytic anemia, pigmented stone, gallbladder, adult, you think of a HS. Think of, right? Obviously, an elevated MCHC, it's a very, 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 very important finding because the only disease where mean corpuscular hemoglobin concentration will be elevated. There's no other disease on the planet where it will be elevated, at least from an undergraduate perspective, fine. Then in peripheral smear, I obviously see spirocytes, right? So we'll see, understand many logics here. It's a biconcave RBC that's becoming spherical, okay? Which means it'll be a little bit shrunken. Remember an rubber band? Left, it'll be a little bit smaller, right? So it'll be a smaller RBC. Since there's a biconcave nature, my hemoglobin actually was in the corners. In the center, it will be compressed, no hemoglobin. That's why we have your central pallor. But here, since it's spherical, I won't have a central pallor. slightly smaller hemoglobin, same amount of hemoglobin production, the concentration becomes a little bit more, right? So here it will be a smaller RBC, it will be a darker RBC, but the most characteristic finding, never ever forget, there will be no central pallor. If you have no central pallor, I'm going to think of a spherocyte, a classical diagnostic finding for a spherocyte. Fine, perfect. So once I see spherocyte in a microscopy, will I jump into spherocytosis? Never. Because it's a genetic disease. Genetic diseases are not definitely common. Acquired diseases are very common, right? So the next step, whenever you see spherocytosis, do a test called a Coombs test, because Coombs is the natural test. This has come in an MCQ multiple times, because the most common cause of spherocytosis, autoimmune hemolytic anemia, rule that out first. If it's not that, then let's look at the other things. But the first thing, when you see a spherocytic anemia, whatever age group it might be, young, adult, elderly, doesn't matter, the first is going to be Coombs test. This is very important. Please do remember there's a PYT based on this concept, even in the last but one NEET PG exam. Fine. Okay. So once I have confirmed that's okay, let's assume Coombs is negative. I need to confirm it is HS. The best test is undoubtedly flow cytometry for with a dye called as EMA, eosin 5 maleimide. Again, for anyone preparing for an INACT exam, this might come handy, because eosin 5 maleimide will bind to the topmost protein called as band 3. It binds to band 3. So if eosin 5 maleimide is negative, then it's an HS. If it's positive, which means it's a normal protein, that's the concept of EMA. EMA or eosin 5 maleimide negative in flow cytometry, thinks of an hereditary spherocytosis, right? That's one simple case. This is a way to revise, right? Just take a screenshot of it, or I'll share this PDF in the Telegram group. Just download them, have them, quickly revise them, right? That should be more than enough for us, right? Next is G6PD deficiency. Very simple. G6PD is an enzyme which is deficient, which is a part of the HMP pathway. Because of this defect, there will be a reduced production of NADP, NADPH, right? So when I have reduced production of NADP, NADPH, my recycling of glutathione peroxidase will not be recycled. Because of the reduced recycling, what I'll have is, you'll have an increased free radical induced damage, because glutathione peroxidase is a free radical scavenger or an antioxidant. Because of this absence, I'll have reduced recycling. So why are RBCs more dependent on recycling? They don't have nucleus, no way to produce new enzymes, so they are totally dependent on recycling. So I'll have more free radical induced damage. That's all. It's an X-linked recessive inheritance. It's a classical finding, which means men are more commonly affected. So since the primary problem is free radical induced damage, so only when the free radicals are more in the body, you'll get the hemolysis. Otherwise, you won't, right? So definitely there's a trigger-induced hemolysis. You'll have a trigger. Infection is the commonest trigger because of more free radical-induced damage, right? Drugs, few drugs, never forget Primaquine. I mean, multiple times repeated in the exams. Dapsone. These are drugs which can easily cause hemolysis. There are multiple other things. Fava beans, which is a type of bean, when you ingest them also, more free radicals, which will cause a hemolysis, right? So classical history here, please remember, your G6PD deficiency can cause both intravascular hemolysis as well as extravascular hemolysis, right? If you have to pinpoint which, this is more common, especially in an acute episode. So there will be a history of hematuria. After an infection, hematuria with some findings in microscopy. These are the two classical findings: bite cell in Hind's body, think of a G6PD deficiency. Or after Primaquine, hemolysis, think of a G6PD deficiency, right? So once you do a peripheral smear, you'll have the classical bite cells. So bite cells will be like this. It'll be like a bite. We might have called it an apple cell if it's a new age person, right? So a bite cell looks like a bite, and they also will have spherocytes, that though that's not a very characteristic finding, and they have a structure called as Hind's body. See, Hind's body is nothing but, it's a denatured hemoglobin. Okay, a denatured hemoglobin which is not seen in a normal stain. It is seen only in a new methylene blue stain. New methylene blue stain is a stain useful for reticulocyte, right? That's why I see the denatured hemoglobin in a reticulocyte stain, and obviously I can easily confirm it's G6PD deficiency. But if I have to have an investigation choice, analyze the enzyme. It's an enzyme deficiency. You analyze the enzyme, automatically you will know the answer, right? I'm sure that this is irritating you. We'll come to that very soon. Fine. So this is what is about, in short, about G6PD deficiency. The way to treat is simple supportive management. That should be more than enough for this patient. Nothing else required. Fine. A very quick revision. Use this as a final resort. A week before the exam, don't know what to do, I'll have one page, one flashcard like thing for every disease which is required for you. We'll learn that. That's it. Fine. Two questions, two screenshots from books. Reticulocyte stains are stained by brilliant closyl blue, new methylene blue. All these are called as supravital stains. Okay, supravital stains means I will not fix this tissue, I will stain them alive. Supravital, I'll stain them when they are alive. Brilliant crescent blue, new methyl blue, they are classical supravital stains and they're useful reticulocytes, right? All of the following are seen in thalassemia major, except, though we didn't discuss about thalassemia, you guys are experts about it, right? Transfusion dependency, splenohepatomegaly or hepatosplenomegaly, ineffective erythropoiesis, macrocytic anemia. Comment the answer. I want you guys to be more and more and more involved. More involved you are, more we learn, right? See you in the next video. Till then, bye bye from Dr. Anjit. Bye bye.